The Functional Gait Assessment, FGA, is described as a modified DGI with improved reliability and decreased ceiling effect. The ICF domain is activity, and the populations tested are general patient populations, older adult and geriatric care, Parkinson's, stroke, vestibular disorders. Equipment required for the FGA includes a stopwatch, a marked walking area of 20 feet long and 12 inches wide, obstacle of 9 inches high, and a set of steps with railings. It takes about 5 to 10 minutes to administer. The special considerations include the physical therapist position did not make a difference in intra-rater reliability, addressed the ceiling effects of the DGI in persons with vestibular dysfunction, and medication adjustments after the FGA may have led to a different cutoff score for patients at risk of falling. When considering the time of the individual's primary PD medication, research reported a predictive validity was much better during off timing than on. It's advised for individuals with PD off medication to improve fall prediction.
Okay, so we're going to do FGA. The first one is gait level surface. So you're going to walk from this yellow cone all the way down to that other yellow cone. Go ahead whenever you're ready.
So normal would be he's able to walk 20 feet in less than 5.5 seconds with no assistive device, good speed, no evidence of imbalance, normal gait pattern. Mild impairment would be he walks 20 feet in less than 7 seconds, but greater speed than 5.5 seconds, or uses an assistive device, slower speed, mild deviations. Moderate impairment would be he walks 20 feet with slow speed, abnormal gait pattern, imbalance, or deviation outside of the range of the walkway width, or requires more than 7 seconds to ambulate. And then severe impairment is that he cannot walk without assistance, severe gait deviations, or imbalance, deviates greater than 15 inches outside of the walkway, or reaches and touches the wall.
You're going to start off by walking as slow at your normal pace, and when I tell you go, you're going to walk as fast as you can, and then when I tell you slow, you're going to walk slow. Ready? Go. Go. Slow.
So normal would be able to smoothly change walking speed without loss in balance or deviation, which shows a significant difference in walking speed between normal, fast, and slow. Mild impairment would be able to change speed with mild deviation, or no deviation, but unable to achieve significant change in velocity, or uses an assistive device. Moderate impairment would be makes only minor adjustments to walking speed, or goes outside of the walkway width, or changes speed but loses balance and is able to recover and continue walking. Severe impairment would be cannot change speeds, large gait deviations, or loses balance and has to reach for water.
Gait with horizontal head turns. Brandon, you are going to walk in a straight line normally. Then, after 3 steps, you're going to turn your head to the right and keep walking in a straight line with your head staying at the right. And then after 3 steps, you're going to turn your head to the left and walk 3 steps to the walking in a straight line. And we're going to repeat that twice. Ready? Go ahead.
So normal would be performs head turns smoothly with no change in gait. Mild impairment would be performing the turn smoothly with slight change in gait velocity. Moderate impairment would be performs head turns with moderate change in speed, slows down, or goes outside of the walkway path. Severe would be performing the task with severe disruption of gait, staggering or losing balance, and stopping or reaching.
This part of the functional gait assessment is called the gait and pivot turn. So Allison, what I'm going to have you do is we're just going to walk at a normal pace down here, and when I tell you to turn, I want you to pivot and turn the opposite direction in a nice, quick, and normal fashion. Okay, so go ahead when you're ready. And turn. Perfect.
So the 3 is a normal pivot turns safely within 3 seconds and stops quickly with no loss of balance. 2, mild impairment, pivot turns safely in over 3 seconds and stops with no loss of balance, or pivot turns safely within 3 seconds and stops with mild imbalance, requires small steps to catch balance. 1, moderate impairment, turns slowly, requires verbal cueing, or requires several small steps to catch balance following turn and stop. 0, severe impairment, cannot turn safely, requires assistance to turn.
Okay. This part of the functional gait assessment is the step over obstacle. So Allison, what I'm going to have you do is we're just going to walk towards the obstacle and we're going to go over top of it, not around it or to the side of it, but I want you to step over it and continue on straight afterwards, okay? So go ahead. Perfect, stop.
So normal is able to step over 2 stacked shoe boxes without changing gait and no evidence of imbalance. Mild impairment is able to step over 1 shoebox without changing gait speed, no evidence of imbalance. Moderate impairment is able to step over 1 shoebox but slow down and adjust steps to clear the box safely, and it may require verbal cueing. Severe impairment you cannot perform without assistance.
Okay, this part of the functional gait assessment is a tandem walk. So Allison, what I want you to do is we're going to go heel to toe, so going 1 foot in front of the other like this, and we're going to walk the straight line down to the next cone there. And once you pass that cone, yes, and have your arms across your chest as well. And once we reach that cone, you will be finished. Okay, so when you are ready.
So normal is able to ambulate for 10 steps heel to toe with no staggering. Mild impairment ambulates 7 to 9 steps. Moderate impairment ambulates 4 to 7 steps. And severe impairment ambulates less than 4 steps heel to toe or cannot perform without assistance.
So this is the FGA gait assessment, gait with eyes closed. So Jean, you're going to walk from this cone to this cone with your eyes closed, and I'll be here to help you with balance. And go.
Okay, normal is going to be walks 6 meters, no assisted devices, good speed, no evidence of imbalance. Mild impairment is walks the 6 meters using assisted devices, slower speed, mild gait deviations. And moderate impairment walks 6 meters, slow speed, abnormal gait pattern. And severe impairment is cannot walk the 6 meters without assisted severe gait deviations or imbalances.
Good. This is the FGA ambulating backwards. So Jean, you're just going to walk backwards until you know yourself. And go.
Okay, normal walks 6 meters, no assisted device, good speed, no evidence for imbalance. Mild impairment walks 6 meters, uses assisted device, slower speed, mild gait deviations. Moderate impairment walks 6 meters, slow speed, abnormal gait pattern, evidence for imbalance. Severe impairment is cannot walk the 6 meters without assisted devices or severe gait deviations or imbalances.
So this is the FGA steps component. So Jean, you're going to walk up these stairs as you would at home. At the top, you're going to turn around and walk down, okay? All right, when you're ready, get started.
Okay, normal is alternating feet, no railing holding on. Mild impairment is alternating feet, but must use the rail. Moderate impairment is 2 feet to a stair, must use the rail. And severe impairment cannot do the action safely.
The retest reliability is excellent for stroke and Parkinson's disease populations. Inter-rater reliability and intra-rater reliability are excellent for stroke, vestibular disorders, community-dwelling older adults, and Parkinson's disease. The ceiling and floor effect are excellent for the FGA. The first week of PT has a 2% floor effect, while the 5 months after PT has a 5.7% ceiling effect. The predictive qualities for the FGA is postural stability during walking tasks for predicting those who are at a risk for falling, and there are no limitations for this assessment.
So I did the motor activity log. The motor activity log is a semi-structured interview to assess the arm function. The ICF domain that it primarily focuses in is the activity, but actually it also is in the participation phase of the ICF domain. And is also only testing stroke populations for the most part after somebody has a stroke to test whether they can use their right or left upper extremities. The equipment that is required is only a paper and a pencil, very cheap, subjective interview. Time to administer the assessment usually takes about 20 minutes, and there are no special considerations to consider for this test. Something to be considered for the motor activity log is there is versions for the upper extremities and lower extremities based on which ones are being tested at the time or have the most difficulties. So The activities are all on the left side. For this one is specifically the upper extremity version. So this is stuff like turn on and off light switches, change the TV channel, open the fridge, wash dry dishes. So the patient is going to put how much they use between the ratings of none, little, some, or a lot, and then how well it's used after the stroke. So do you have full range to do it? Do you have moderate ability to do it? Do you have no range or no ability to do it? And then additional comments afterwards. So this test isn't something that's based on number necessarily. This is more based on subjective opinion of what the patient thinks they actually need and what they have difficulties doing, so that the PT can then form a plan based on more things that they use more frequently and things that have more difficulty doing as well. And that's more important to the patient specifically, rather than just a number to place out of like 10 or 20 saying this is how good something's done. If the patient has a pretty formal way of being able to tell this is how much I'm using something and this is how badly I have been affected since then and how I can't do it. So that's how the motor activity log works, is based on mainly just function and the ability for the patient to form their own plan and tell the PT what they think is incorrect with after having a stroke on a side of their body. The motor activity log has a stroke reliability of excellent, of 0.70 to 0.85 and 0.61 to 0.71. The stroke validity for the motor activity log has an excellent current correlation between stroke impact scale hand function scores of 0.72, adequate concurrent correlation between accelerometry of 0.52, and excellent concurrent correlation between action research arm test of 0.63. There are no ceiling or floor effects for the motor activity log that should be considered. The measure does, however, have predictive qualities, a level of function of the affected arm that has had the stroke, and how much they use it in their daily activities for functional purposes. There are no limitations to this assessment, since it is a written subjective assessment based on the patient's perceived function of their affected arm.
The NIH Stroke Scale assesses severity of symptoms and deficits post-CVA. The ICF domain is participation according to the Academy of Neuro-PT, or body function according to sralab.org. The populations tested are stroke patients, and the equipment required is just paper and pencil. It's free to administer. Time to administer the test is only 6 minutes. Some special considerations are that NIHSS is most useful for early prognosis assessment, whereas the Barthol Index may be more useful for intervention planning. And the measure is originally designed to assess differences among clinical trial interventions, but it is increasingly used as an initial tool and for planning post-acute care. It does have poor reliability and redundancy on 4 items, and those are level of consciousness, facial weakness, ataxia, and dysarthria. Okay, so the first part of the NIH stroke scale is assessing level of consciousness. So I would just come into the patient and provide some sort of tactile simulation to see if they respond. So hi Jean, how are you doing today? Good. And the second part would be assessing level of consciousness questions. So Jean, do you know what month it is today?
September.
Good. And do you know how old you are?
25.
Perfect. So for the first one, a 0 would be if they're alert and keenly responsive to the touch. A 1 would be they're not alert, but they're aroused by minor stimulation, so they move their arm, but they don't really give me a verbal conscious response. Not alert, they require repeated stimulation to kind of acknowledge that the PT is there. And then 3 would be respond only with reflex, motor, or autonomic effects, but they're otherwise unresponsive, flaccid, areflexic. And then the questions, 0 would be if they answer both correctly, 1 would be answers one question correctly, or 2 would be answering neither correctly. So Jean would get a 0 for both of those. Okay, so the next part of NIH stroke scale is the level of consciousness commands. So you're going to ask the patient to open and close their eyes and squeeze their non-paretic, affected side hand. So, Jean, can you open and close your eyes for me? Just kind of let me know you're listening to me. Perfect. Can you give me a hand squeeze? Good. So a 0 would be if they can perform both tasks correctly, a 1 would be if they perform one task correctly, and 2 would be they perform neither. So Jean would receive a 0 for that as well. The next part would be best gaze. So we're looking at horizontal eye movements. So Jean, can you look at my finger for me? Good. Over here. Good. So 0 would be normal, 1 would be partial gaze palsy, so it's abnormal in one or both eyes, but forced deviation or total gaze paresis is not present, and then a 2 would be forced deviation or total gaze paresis not overcome by oculocephalic maneuver. And then the next part is looking at visual fields, so you can do the typical H and just kind of see if they're able to look at your finger through all parts. So keep an eye on my finger again. All different angles of the eye. So 0 would be no visual loss, 1 would be partial hemianopia, so if they can't see on one side, 2 would be complete hemianopia, or 3 would be bilateral, so they can't see any of it. Okay, so the next part of the NIHSS stroke scale is facial palsy. So you're gonna ask the patient to make some facial expressions to see if there's any paresis in the face. So Jean, can you show me your teeth? Good. Can you raise your eyebrows? Can you close your eyes? Perfect. So 0 would be if they have normal symmetrical movement, no limitation. 1 would be minor paralysis, so just a little bit of asymmetry. 2 would be partial paralysis, so a more significant difference from side to side, or 3 would be complete paralysis on one. Okay, so next we're gonna look at motor function of the arms and the legs. So Jean, can you raise this arm up for me? Good, go ahead and hold it there, okay? Hold, hold, hold. So the patient's gonna hold for 10 seconds. If they are unable to hold it for 10 seconds, it's considered drift. So, say 10 seconds, good, go ahead and lower that arm down. So a 0 would be no drift, and then they're able to hold it for the full 10 seconds. 1 would be if they have drift, but it doesn't hit the bed, like it's a slower control. 2 would be some effort against gravity, but they can't really fully get it off. 3 would be no effort against gravity, the limb just completely falls down. 4 would be no movement at all. And you would test each arm one by one. So the next part would be the leg. So similar thing. Jean, can you raise this leg up for me? Good, go ahead and hold it there. And for the legs, they only have to hold it for 5 seconds. So good, go ahead and lower down. A 0 would be no drift, 1 would be some drift. It falls before 5 seconds is over, but it doesn't hit the bed. So it's controlled. 2 would be some effort against gravity, but it eventually falls to the bed. 3 would be no effort against gravity, so they can't, they'll raise it up and then it falls immediately. 4 would be no movement whatsoever. Okay, so the next one is limb ataxia. So you're gonna assess whether the patient can do finger, nose, finger, and heel, shin on each side. So Brandon, can you touch my finger? Good. Can you touch your nose? Then can you touch my finger? Good. Can you do it with the other side for me? Same thing. Touch my finger? Good. Good job. So 0 would be they aren't able to do it, and 1 would, or they are able to do it with no issue, I'm sorry. 1 would be if they have lack of coordination on one side, 2 would be they have lack of coordination on the other side. And then same thing with the heel shin. So Brandon, can you bring this foot to this leg right here? Just kind of cross it like that. Good, go ahead and lower down. Same thing on this side, go ahead and bring this foot to this heel. Good, go ahead and lower down. And then the next thing you're gonna look at is sensation to grimace or pinprick. So you're gonna focus on the distal extremities, hands and feet. So can you feel this little pin touch right here on this hand? Good. And go ahead and close your eyes for me, okay? Same thing on this side. Can you feel the sensation? Good. I'm gonna come down here, okay? Can you feel it on your ankle?
Yes.
Good. What about this side?
Yes.
Good. So 0 would be no sensory loss, everything's fully intact. 1 would be mild to moderate sensory loss. They feel pinprick, but there's loss of superficial pain, and they're kind of aware of being touched. And then 3 would be severe to total, so they don't feel it at all. Okay, so next you're gonna look at the patient's language comprehension for aphasia. So I'm gonna show Brandon this picture, and he's gonna need to describe what's happening. So Brandon, can you tell me what's going on in this picture?
Kids are stealing cookies from the cookie jar behind their mother's back. It looks like chaos everywhere, actually.
Oh yeah, definitely. Good job. Okay, and then you can are also going to have them name the objects in this picture here. So Brandon, can you name these objects for me? What is this?
Love.
What is that?
Key.
What's this?
Cactus.
Good. What is that one?
Chair.
How about this one?
Feather.
And this one?
Hammock and trees.
Great job. And then lastly, you're gonna have your patient read the sentences on this sheet. So Brandon, can you go ahead and read this sentence for me?
You know how? Down to earth. I got home from work. Near the table in the dining room, they heard him speak on the radio last night.
Great job. So using all of those, you would see if there's any sort of aphasia, so difficulty expressing words, or their response not matching what you would expect. So 0 would be no aphasia, they're totally normal. 1 would be mild to moderate aphasia, so they have some issues with comprehension or expression, but it's not severe. 2 would be severe, and then 3 would be mute. Either they're unable to communicate verbally or they have global aphasia. So the next part of the NIH stroke scale is looking at dysarthria. So I'm going to have my patient read this list of words right here and just see if he's having any difficulty with the motor component of speech. So Brandon, can you read these words to me on this sheet?
Mama, tip top, 50-50, thanks, Huckleberry, baseball player.
Great job. All right. So 0 would be normal, which I would score him as 0. 1 would be mild to moderate dysarthria, so they're slurring or having difficulty with producing the words. 2 would be severe dysarthria, so slurred it's unintelligible, or it's mute, very quiet. And then you would also give a UN score if they're intubated or unable to test. Okay, so the last part of the NIH stroke scale is for extinction and inattention, so formerly known as neglect. So I'm gonna see if Brandon has visual and or cutaneous neglect. So Brandon, can you see my fingers over here? How many fingers am I holding up?
2.
Good. What about over here? Can you see how many fingers I have over here?
2.
Perfect. Now tell me how many I have on both sides.
2 and 2.
Awesome, good job. And then the cutaneous part. Brandon, go ahead and close your eyes for me, okay? Am I touching your right arm or your left arm?
Right arm.
Good. Am I touching your right leg? Yeah, right arm or left arm?
Left arm.
Good. What about right leg or left leg?
Left leg.
Good. Right leg or left leg?
Right.
Good. Go ahead and open your eyes. So for that, you would obviously need to see if aphasia or visual impairments are present before you're able to see if you can test this. But a 0 would be no abnormality, which you would score 0. 1 would be visual, tactile, auditory, spatial, or personal inattention. So they have some impairment with any part of the test. 2 would be profound hemi-inattention or extinction to more than one modality. So they don't see cutaneous or visual. So the test-retest reliability for the NIH stroke scale is excellent. The inter-rater reliability and the intra-rater reliability were adequate to excellent for 9 out of the 13 items. The 4 that had poor reliability mentioned on the previous slide are excluded from that. The ceiling floor effects, the floor effects are less commonly reported in current literature, but the ceiling effect is observed at 6 months with NIHSS affecting 20% of patients who completed the measure. Predictive qualities, it helps the PT gain a better understanding of general prognosis or ability of patient to respond to PT. And limitations of the assessment, again, are that 4 out of 13 of those components of the outcome measure demonstrate poor reliability, and there is a need for developing a refined outcome measure that discludes the 4 out of 13 components with poor validity.
9-hole peg test measures finger dexterity and upper extremity function. The only cost is material, and the test is free to perform. There is not an ICF domain according to the Academy of Neurologic Physical Therapy, because the literature search did not reveal new psychometric data available. The 9-hole peg test tests populations of stroke, multiple sclerosis, Parkinson's disease, and non-specific patient population. The equipment required is a paper and pencil and the pegboard. The time to administer is less than a minute, and special considerations are sensitive to practice effects, and it takes about 3 to 4 administrations is recommended before taking a baseline assessment.
This is a 9-hole peg test. So the instructions are you're going to pick up the pegs one at a time using your right hand, your dominant hand only, and then put them in the holes with in any order until the holes are filled. Then remove the pegs one at a time and return them to the container. Stabilize the pegboard with your left non-dominant hand, and this is a practice test. So let's see how fast you can put all the pegs in and take them out. Ready, set, go. Good, and then out. Oh. Good. So, now this was going to be the actual test. The instructions are the same. Work as quickly as you can. Are you ready? Go. And I started the stopwatch when the first peg hits. Faster. Faster. Okay, now out again. Faster. Good. And it stops when the last peg hits the container. That's the test.
Retest reliability is excellent for the entire group and individuals without hand spasticity and adequate for individuals with hand spasticity. The inter-rater reliability for stroke is adequate to excellent, while the inter-rater reliability is excellent. The criterion validity is adequate with the stroke impact scan hail function domain at pre-treatment and excellent for post-treatment, and adequate to excellent with the box and block. The construct validity is excellent with the monstrosity index. For the ceiling and floor effects, participants are assessed twice, the first at discharge and the second at the 6-month post-discharge. 100-second cutoff is for this test, and if the patient exceeds 100 seconds, they receive a score of 0. At discharge, the adequate flora effects is less than 20% of the participants receiving a minimum score, and at 6 months post-discharge, fewer participants receive the lowest score possible. The predictive qualities for the 9-hole peg test are finger dexterity, ability, and the limitations is if the patient is unable to complete the test due to decreased finger dexterity or cognition.